In this video, we perform the repair of an acute type A aortic dissection using a fenestrated frozen elephant trunk technique. This is a 36-year-old male with a past medical history significant for hypertension who presented with severe tearing chest pain. CTA demonstrated a type A aortic dissection stemming from the aortic root to the visceral abdominal aorta. The branch vessels are not involved. The true lumen appears severely compressed. CT imaging is from an outside hospital with limited visualization of the abdominal aorta below the origin of the SMA. The left kidney does appear to be hyperperfused. Midline sternotomy was carried out in standard fashion. The innominate vein was then dissected out and encircled with an umbilical tape. The innominate artery was then freed and encircled with a vessel loop. The left common carotid artery was also controlled, followed by creating a pericardial well. The immediate ascending aorta appeared bruised, consistent with a type 1 aortic dissection. 2 pleated purse string sutures were then placed in the distal ascending aorta, as well as a purse string suture along the right atrium to accommodate arterial and venous cannulation. The ascending aorta was then carefully mobilized from the pulmonary artery trunk and circumferentially freed to prepare for cross-clamping. Systemic heparin was administered. Once therapeutic, the ascending aorta was accessed using a Cook needle. A Benson wire was then directed into the true lumen under TEE guidance, and a 22 French arterial cannula was inserted over the wire. The right atrium was cannulated with a multi-stage venous cannula. Cardiopulmonary bypass was then initiated with a cooling target of 25 degrees centigrade. The right superior pulmonary vein was then cannulated to act as a left ventricular vent. A retrograde cardioplegia catheter was directed into the coronary sinus under TEE guidance. The ascending aorta was then cross-clamped and retrograde cardioplegia was initiated. The ascending aorta was transected just above the sinotubular junction. The left and right coronary ostia were visualized, and del nido cardioplegia was directly administered. An intimal tear is noted in the posterior aspect of the ascending aorta just above the sinotubular junction. The coronary ostia are noted to be intact. Given that the coronary ostia were intact and the aortic valve was noted to be trileaflet, free of calcification and with good coaptation, the decision was made to pursue valve resuspension. A felt patch was then inserted into the dissected sinuses and secured at the sinotubular junction with running 5-O-proline in 2 layers. The sinotubular junction was sized and measured at approximately 29 millimeters. After reaching 26 degrees centigrade, the cardiopulmonary bypass circuit was stopped and the cross clamp was released for circulatory arrest. The aortic cannula was removed and the aorta was transected up to the level of the innominate artery. A balloon-tipped perfusion catheter was then inserted into the innominate and left common carotid artery for antegrade cerebral perfusion. The aortic arch was then inspected for any entry or exit tears. None are noted. A Benson wire was then advanced down the true lumen of the descending aorta, and a Gore conformable thoracic stent graft measuring 31 millimeters by 10 centimeters was deployed in an antegrade fashion. The graft was then secured along the greater curvature of the arch with 2 interrupted 4-O-proline sutures. A fenestration was then made in the graft at the ostium of the left subclavian artery using an ophthalmic cautery. An 11 by 29 millimeter Viabon balloon expandable stent was then deployed through the fenestration into the left subclavian artery. A single sidearm aortic graft was then brought onto the field and appropriately trimmed and beveled. Running 4-O-proline suture was then used to complete the distal anastomosis. The anastomosis was fortified with an external felt strip. The TVAR graft was incorporated into the anastomosis along the lesser curvature. The 10mm antiflow sidearm of the graft was then connected to the cardiopulmonary bypass arterial line. The graft was then de-aired and systemic perfusion with rewarming was initiated. The aortic valve commissures were resuspended with pleated fluoroproline sutures and brought through an externally wrapped felt strip. The proximal graft was then anastomosed to the sinotubular junction with running fluoroproline suture, incorporating the externally wrapped felt strip. A Bengay needle was inserted into the graft to de-air, the aortic cross-clamp was removed, and the heart returned to a normal sinus rhythm. The patient was rewarmed to 36.5 degrees centigrade. Post-cardiopulmonary bypass TEE demonstrated preserved biventricular function with good function of the native aortic valve and no residual aortic insufficiency. Post-op CTA demonstrates a satisfactory repair. The left subclavian stent is patent. The dissection flap extends from the thoracic aorta to the bilateral iliac vessels. The true and false lumen appear patent with significant improvement in true lumen compression. All visceral arteries are widely patent. With the exception of the two right renal arteries, all visceral branches stem from the true lumen. A small infarct is noted in the lower pole of the right kidney. The patient had an uneventful postoperative hospital course and was discharged home post-op day 7. Thank you for watching.